we've all been sort of brought up on metformin as the first drug for diabetes.
What about the Ozempic face? You know, the glow, so to speak, is lost in so many celebrities.
You're looking for maybe unrealistic goals.
What would be the drawbacks be?
Don't depend on the drug alone. People with diabetes who are put on GLP-1 lose less weight than those without diabetes.
Would you prescribe a GLP-1 medicine, or would you ask that patient to stick to metformin?
Remember, GLP-1 field is just beginning to explode. There'll be many newer drugs with less and less side effects and easier to use. We don't have to repeat everything the West has done.
Well, how do I lose weight? That's actually one of the most common questions that just so many people want the answer to. It's a big talking point. Everyone is interested in losing weight. It's in fact one of the most searched topics on social media. Well, doctors are answering that question. Dr. Ambrish Mithal has written a book on it. It's called The Weight Loss Revolution, and it answers many questions around weight loss and weight loss medication. It talks about this as a weight loss revolution because it is. GLP-1 medications and the interest around weight loss medicines, which are now available in India, at least one is in the pipeline, is going to help diabetic patients control their weight, and who are not diabetic as well can get some benefits, as weight loss is the outcome of it. Dr. Ambrish Mithal is now joining us. Thank you so much for your time. You are in fact tuned into our new show, which is Booked, and we'll discuss your book, and you also have to answer some questions around weight loss.
Sure.
What exactly is going on? You call it the revolution. In the phrase that you use, the term that you use is revolution, and many do see it as a big change in the pharmaceutical industry and in the health landscape as well. You know, for the longest time in India is the diabetes capital of the world, as we know, and metformin is being used. But you write in your book that you say the tide in fact changing in favor of GLP-1 medicines. Just tell us, why do you say that?
So we've all been sort of brought up on metformin as the first drug for diabetes because metformin is safe. It has virtually no long-term side effects, possibly causes a little bit of weight loss, and possibly protects the heart a little bit in the long run. But with the newer drugs, particularly GLP-1 drugs, and there are also another class of drugs called SGLT2 drugs, with these drugs, you're moving far ahead of metformin. Because there is clear evidence that these drugs produce significant weight loss, and not only that, there is clinical trial data suggesting that they protect your heart, they protect your kidney, they very likely protect your liver too. So with this hard evidence based on solid clinical trials, these drugs are bound to replace metformin somewhere down the line, sooner rather than later, as first-line drugs.
All right, as first-line drugs, GLP-1 medicines are the common names that all of us are now familiar with, which is Ozempic. Also the other drugs that you could mention, sir.
Yes, Ozempic or Wegovy and Mounjaro or Zepbound. So I think in India, the relevant names are Mounjaro, which is already available, tirzepatide, or Wegovy, which I understand will soon be available in India.
But even before the medicine was available, as you write in your book, lots of patients were actually procuring it from outside of India. Ozempic is not in India, but they get it from other countries because of the drastic effects that they see in terms of weight loss. I want to ask you, if a person comes to you, if a patient comes to you and says, I'm diabetic, but that person is not clinically obese, would you prescribe a GLP-1 medicine, or would you ask that patient to stick to metformin?
I think there are certain categories of diabetes where these drugs clearly score over the drugs. And you have to remember that type 2 diabetes, which is the common variety of diabetes, is primarily driven by excess body fat. So 80 to 90% of people with type 2 diabetes would be those who have excess body fat. So such people would automatically be candidates for GLP-1 drugs. So I think that's how you have to look at it. The vast majority would be candidates, but there would be some, of course, who are the lean type 2 diabetic, or somewhat different in their pathophysiology or in their manifestations, who would not be candidates.
Right.
But the bulk, the large chunk of type 2 diabetes patients are overweight, need to lose weight, and losing weight will help them either even reverse or at least treat their diabetes better.
You know, I also want to ask you, nowadays there's a lot of chatter about the fact that BMI clearly shouldn't be an indicator. In fact, it is misleading. Just tell us, why is BMI misleading? And rather, you write in your book as well that the fact is that right now you have to look at your body fat percentage, and that would be a more accurate way of determining whether a patient is obese or not.
Correct. So BMI is the most convenient method,
Yes.
time-tested and honored method, because it just takes into account your height and your weight. That's it. Now, it doesn't take into account how much of that weight is coming from muscle. It doesn't take into account how is the weight distributed. Not all weight is the same.
Right.
So if you use just BMI, that is height and weight, you will end up with a lot of Indians being classified as healthy in the BMI category when they have
Belly
actually a
fat.
lot of central fat. And is the central fat or the belly fat or the visceral fat, that is actually the bad fat. So using just BMI would mislead us into thinking that, one person is healthy, whereas actually the person has a lot of central fat and therefore is clearly unhealthy and needs treatment.
All right, so BMI needs to go out the window, clearly. That is the calculator. Needs to go out the
It
window.
won't go out of the window because it's been there for so long and
Right.
used in so many studies. But definitely one can look at waist circumference,
Yes.
waist-hip ratio.
Yes.
And if you move ahead, body composition analysis, which is not so difficult anymore, which will tell you the actual percentage of body fat that you have.
You know, I also want to ask you, and you write this, the book also talks about it in detail about the fact that many Indians are actually skinny fat. They might be thin all over, but they may have like a pot belly. This could be because of anything. Cortisol fat as well, I would believe, cortisol belly also. But, why is this particularly risky? Why is this particularly problematic? You say fat around the thighs and your arms isn't particularly worrying, isn't it?
Yes, because as I said, all fat is not the same. Hence,
Yes,
the BMI,
yes.
importance is less. We call it TOFI, T-O-F-I, thin outside, fat inside.
Okay.
Okay, and that's typical of South Asians or Indians. So the fat around the viscera, that is inside, around our organs. Viscera means organs. That produces a lot of dangerous inflammatory substances, different kinds of cytokines or chemicals, if you may, which incite inflammation across the body, including the pancreas, including the heart, kidney, everywhere. So that fat, if that is excessive, that is very dangerous, as compared to fat on the arms or the thighs, which is direct subcutaneous fat, which may not be that dangerous per se.
Okay.
So there's a big difference in the kind of fat.
Okay. When it comes to GLP-1, yes, there is an initial days, there was a lot of conversation. And now also, nausea, just feeling sick. I hate food. My relationship with food has turned sour. These are
Yes.
usual statements
Yeah.
that you get to hear from people on these medicines like Ozempic, Mounjaro. I just want to ask you, what would you say is problematic here? And what should be the do's and don'ts for those people on these medicines? And how should they be, number one, exercising, and also, watching their calorie intake and eating the right kind of food?
Yeah, I think the first thing to emphasize here
Yes.
is that if you're using these drugs for weight reduction,
Yes.
don't depend on the drug alone. So I'm answering your last part first. Basically, it's important that we understand that using so-called weight loss drugs or GLP-1 drugs is actually part of a program, which includes dietary advice, in particular, increase your protein intake because your diet is going to go down.
Yes.
So if you're eating half of what you were eating earlier, then you can't afford to have half the protein, right? So increase the proportion of protein in your diet.
Right.
Increase the proportion of fiber in your diet. Each single meal should be small. Don't have single large meals. The moment you have a large meal, supposing you don't eat all day and then you have a large meal in the evening, you will certainly feel sick. So small meals is important. Sometimes just walking after meals, 5 to 10 minutes, makes a big difference. So all those kind of things are important. Obviously, you know what to avoid. You know that you have to avoid fried food. You know you have to avoid baked or high carbohydrate food. Those things are not that great for us. The moment you follow these things or don't follow these things, your body will tell you if you're not following. As I said, you'll feel sick and you may want to throw up. That's one thing. In the long run, if you're not following a healthy diet with this, you will end up with significant muscle loss. And this is not because of the weight loss drugs. Whenever we lose weight, we also lose muscle. So roughly 20-30% of the weight. So if you lose 10 kilograms, you've lost 2 to 3 kilograms of muscle. Now, if you want to preserve that, and studies are showing that very clearly, you have to ensure adequate protein in your diet. And along with that, you have to make sure that you're exercising regularly, and that exercise should include strength training.
I was coming to that. By exercise, not taking a walk in the park, but lifting weights is what you're saying, because muscle loss is inevitable, and hence exercising in a way is going to stop that to an extent?
Yes, significantly. Significantly. So if you think of the GLP-1 drug, if you're using it for weight reduction alone, if you think of it as a part of your weight loss program, then you'll succeed. Then you'll know, you'll not lose that much muscle. You'll be healthier overall. And when the time comes to later on taper them or reduce their dose, you will be in shape to do that. If, on the other hand, you're using the drugs because they'll make you lose weight anyway. If you're using the drug using the drug just as a weight loss drug and doing nothing else, you will lose weight, but you will also lose muscle. And then when you try to reduce the dose, the weight will start coming back on. So there's a bit of a challenge there.
You've touched upon the Ozempic butt here, and I think that is related directly to muscle loss and sarcopenia. But what about the Ozempic face? What happens to the face? Because, the glow, so to speak, is lost, and so many celebrities have taken this medicine. They'll never admit that they have. And I really don't know what the stigma is also, Do touch upon that.
So when we lose weight rapidly, we lose subcutaneous fat. So the fat and the skin becomes a little lax. This is particularly in older people where skin tends to sag anyway. So if you suddenly lose weight, don't hydrate yourself well, not eating the right kind of balanced diet, and you're looking for maybe unrealistic goals for weight loss, then you get that little sagging on the face, which people have started calling Ozempic face. Forget this. Before these drugs came into the market, anyone we put on a very strict diet or someone who had bariatric surgery would have similar things. But now it is called an Ozempic
Like a bariatric surgery would also have similar.
Absolutely.
You can see it actually,
It's basically loose skin.
Loose skin. All right, I mentioned at the outset that just so many Americans are taking it, and for a country like America where obesity levels are going through the roof, it's perhaps the need of the hour. But in India also, we have twin problem of diabetes and obesity. So technically, we are the diabetes capital of the world. So you see this medicine picking up, people taking this medicine in India. What would be the drawbacks be? I mean, I think this is fairly still expensive, to make it accessible to a larger population for health reasons. How do you see this happening?
So I see these drugs as very important tools in our armamentarium to treat diabetes and obesity. I don't see them as public health measures. You can't eradicate obesity by using these drugs. You have to eradicate obesity by preventing it, by lifestyle measures, not allowing children to become fat, to gain weight. It is weight that drives development of diabetes. When we say India is the diabetes capital of the world, it's because our obesity is also increasing the same way. So obesity increases, then diabetes increases, by and large. So they go hand in hand. So if you want to prevent that, you'll have to use the same lifestyle measures at an individual level, at a family level, societal level, government level. And these drugs are reserved for those who actually need treatment for their overweight, obesity, or diabetes.
I was actually wanting to touch upon that as well. You've spoken about the Green Revolution and how that actually did more harm than good. I would
No,
say
no,
in
no,
a way.
no, that's not correct. I didn't say
no,
that.
No, you didn't
but,
say that.
yeah.
But what I'm trying to ask you
Yes.
is that the very fact that millets and other grains went really out of the window,
Yeah.
and what happened was that high yield wheat came in, and
Yes.
that actually drove, in many ways, the obesity, the problem in India, the silent epidemic of obesity in India, isn't it?
So I think that's a good point. That's
Yes.
worldwide.
Yes.
Whenever we try to fight starvation, the only answer is cultivation. And when you cultivate wheat or rice,
Yes.
at least people will not die of starvation or hunger.
Yes.
That is the easiest way to do that. But when you're sort of propagating that, then people get sort of used to that diet, and that is just easier, and it's also more palatable. As a result, what happens is that the other constraints of diet sometimes get neglected. So our diet over the years has become predominantly cereal-based or carbohydrate-based
Right.
because of roti and chawal, because of wheat and rice. So therefore, it has become more and more processed. So all the fiber goes out. So you really have a diet that, so in that sense, while any such sort of effort like the Green Revolution,
Yes.
which saved us from malnutrition and starvation, but in terms of chronic disease, because we encouraged, obviously, the use of cereals, you ended up with all these problems. So we have to balance it out. We don't have to repeat everything the West has done.
Right.
We really have to stop it in its tracks now.
Okay, right. Coming back to the medicine, a lot of people have this question. I'm sure you get it also from your patients that have been on the medicine, but I haven't even lost a kilo or maybe 2. What do you have to tell those people who are not losing weight in spite of the fact that they're on medicines? And, where does the research stand on, what's really going on? What could be the factors responsible for the patient to be in that situation?
So, yes, I mean, that's very important to understand. That's how biology is. Every person is different. No two people are exactly the same. Same drug works well on one person, doesn't work well on the other. You see that all the time.
Yes.
So GLP-1 drugs are not different. It is true that there's a wide range of variation in responses to GLP-1 drugs with regard to weight. There is less variation in their responses with regard to diabetes.
Okay.
Most people respond very well.
Okay. So basically, diabetic patients are not losing much weight.
So the other thing is that who are the people who don't lose much weight on GLP-1 or lose less weight? So people with diabetes who are put on GLP-1 lose less weight than those without diabetes.
Okay.
So diabetes itself is a bit of a deterrent to weight loss. So roughly, say 60% of weight loss in people with diabetes as compared to those without diabetes.
Okay.
So let's say if a diabetic loses 15 kilograms.
Right.
Maybe a non-diabetic, someone who does not have diabetes loses 15 kilograms.
Yes.
Someone with diabetes may lose only 10.
But why?
So there are multiple factors.
Okay.
So this is the hottest area of research in the GLP-1 field right now. Why do some people not lose weight? Diabetes is only one of the factors. There could be many other factors, including their level of insulin resistance, their genetic predisposition, their concomitant drug therapy, very important. If they are on insulin and other drugs, that reduces weight loss. But also, those who make a greater effort with their lifestyle, they lose more weight.
Okay. I'm going to run through some quick questions with you. Okay, sir. But, I just want you to tell us a little about the fact that, you touched upon how those with diabetes lose less weight. But, many people say that once you stop the medicine, the weight comes back, so it's lifelong. I know it's hotly being debated as well. But is there any truth to it, that you have to take it throughout your life?
So, well, I think it depends on what stage of life you're being given the drug and why is it being given. So if you're a 65-year-old diabetic who's been put on the drugs because, for various reasons, you're likely to use it lifelong.
Right.
And there's no reason to worry about it too much. But if you're a 30-year-old or a 25-year-old who's been put on the drug for, losing weight and planning your family or reducing the risk of diabetes, you certainly should not use the drug. At the moment, the evidence is not strong enough to say that I'm prescribing this for weight to a 25-year-old and the person should use it lifelong. At the moment, I mean, I know people say that, especially Americans say that, but I would be wary. I would take a deep breath after 2 years and see what do I do now, which direction do I go. Maybe newer drugs will appear, which is happening. Remember, GLP-1 field is just beginning to explode. There'll be many newer drugs with less and less side effects and easier to use. You talked about access. Right now, most drugs are injectable, although it's once a week. They have gastrointestinal side effects, nausea, vomiting, etc.
I also want to touch upon that very quickly.
Yes.
Very rare but very serious side effects, like thyroid cancer, for example, if I'm not mistaken. Also the fact that there are some side effects which are good as well. We've heard of Ozempic babies also. I believe it's helped women, and this is anecdotal also. Women conceive, women who are told you can never conceive naturally, have conceived after being on this medicine. So would you want to touch upon
that? So one line about thyroid cancer, exceptionally rare type of thyroid cancer called medullary thyroid cancer, suspected but not proven to increase. So the cancer itself is very rare.
Right.
And the proof that it's really associated is not established.
Okay.
Now, about the happy side effects. Yes, that's what I've called it. The happy side effects means that the data on these drugs, which is very exciting for us as physicians, is Alzheimer's disease. So the evidence that they might be helping Alzheimer's by helping obesity in the brain may actually be very exciting and very
also
interesting.
Cardiac health.
Parkinson's disease. And of course, that I said initially, that these drugs help cardiac outcomes are clearly better. Cardiac events are reduced. Fatty liver is reduced. Kidney disease progression is reduced. No question about that. But the brain effects are particularly fascinating. And there are so many other, sleep apnea goes down. Fertility, you were saying. When you treat a girl with polycystic ovarian disease with these drugs, you may be helping her conceive. And a flip side in that is important is girls who are on birth control pills for contraception, they may actually, the birth control pill efficacy may go down. And some people have been reported to conceive while they are on birth control
I think it's
pills.
important, Dr. Mithal, to underscore, and for our viewers as well, that even in the happy side effects and the serious side effects, a lot of this is in the realm of research, isn't it? These are new drugs. 2005 is not too many years ago. But these drugs have been around, but of course renewed interest, renewed research in this area will in months and years to come answer many of these questions that we've been asking Dr. Mithal. I'm going to thank you for joining in.
Thank you.
It was a pleasure having you on the show.
Thank you.